The 5-Minute Thoracic Outlet Syndrome Review. Let's review the differential for neck and/or arm pain first. Remember to screen for visceral pain by asking about chest discomfort, squeezing or pressure associated with arm pain. For distal neurovascular involvement of the arm, remember the Allen's test for vascular and the entrapment tests for median, ulnar, and radial involvement, primarily for pronator and radial and cubital tunnel compression. These can often be determined by resisted elbow flexion with the elbow in maximum flexion and resisted pronation and supination. Some examiners use variations of the upper limb tension test to localize to a specific peripheral nerve, but the reliability for this is in question. Cervical radiculopathy is due to foraminal encroachment 80% of the time, therefore it's more common in the senior population. 20% is due to disc herniation related either to degeneration or single event trauma. The diagnostic cluster is orthopedically to test for provocation with Sperling's and upper limb tension test, relief with the distraction test, and check range of motion actively for less than 60 degrees of rotation. Neurologically, look for a DTR effect, myotome weakness, and dermatomal numbness. There are numerous trigger point referral patterns. Look for the most common and their referral zones as per Travell and Simons. Sclerotogenous referral is likely when all orthoneuro testing is negative or normal. These referral patterns are more diffuse and overlapping than dermatomal patterns. The T4 syndrome is hypothetically proposed as dysfunction of the sympathetic supply to the arm, which is primarily vascular. Levels are T1 through T6 and as far down as T9. Provocation with thoracic spine pressure over the involved areas or relief with thoracic adjusting is helpful in confirming. Again, there are no orthoneuropositives. Parsonage-Turner syndrome is fairly rare but may follow a respiratory infection and therefore may be due to a viral infection of the brachial plexus or peripheral nerves of the shoulder and arm. Neurodeficits are not apparent until several weeks after the onset, after pain is decreased. And finally, a burner or stinger is a single event lateral flexion injury to the neck with usually transient arm pain, numbness, or paresthesias dependent on the degree of damage. Let's now do a quick review of TOS testing maneuvers. Positives may include a diminished or absent radial pulse and/or reproduction of arm complaints. In A, we see Adson's test, which is hypothetically for the anterior scalene. The patient is instructed to look toward the same side while the examiner palpates the pulse and monitors for a decreased or absent pulse or reproduction of symptoms. In B, we see Halstead's test. It's hypothetically for the middle scalene. The patient is instructed to look away from the involved side with some arm abduction on the involved side. Positives are the same as for Adson's. In C, we see Wright's test for hyperabduction, and it's performed with the arm raised in abduction and horizontal abduction while the examiner determines the pulse or symptom changes. This is for pec minor involvement. And D is the Roux test, where the patient raises their arms and repeatedly grips and releases the grip in an attempt to reproduce symptoms or a sense of weakness. The gripping and release are usually instructed to be at 20 to 60 seconds. Not pictured is the costoclavicular test, where the patient is instructed to assume a military posture and the examiner checks for the usual positive responses. And Tennell's, which is performed by tapping the supraclavicular fossa with a reflex hammer for tenderness. The literature has shown that these tests are unreliable as single tests, which is why the cluster of 5 proposed by Gillard is recommended. This includes Wright's, Adson's, hyperabduction, Roux, and Tennell's. Some suggested additional tests are based on the observations of Travell and Simons for scalene tightness. The cramp test is performed by the patient placing their jaw into the supraclavicular fossa on the same side to see if this causes cramping, and if positive, have the patient repeat with the arm elevated to see if the cramping is relieved, called the scalene relief test. Obviously, there are numerous approaches to management based on the type or subtype of TOS. Suggested is to categorize nonspecific neurogenic TOS into area and structure of involvement, address postural issues broadly, such as using in-office and home stretching approaches for specifically determined soft tissue involvement. For example, corner stretching for pecs and corner mid-scapular contraction and isometric hold for postural improvement, and also deep neck flexor training with chin retraction with concomitant isometric flexion against the palm at the forehead. Address myofascial components through instrument-assisted soft tissue mobilization or similar approaches, and address neural components utilizing flossing, stretch, or tension approaches, and adjust related C-spine and T-spine restricted segments.